I'm excited to speak to everyone on this topic, drawing on 14 years as implant restorative director at University of Pacific in San Francisco, and then also having the opportunity to experience a visiting scholarship at Stanford Animal Research Lab. Both of them have been central in my understanding of this topic. And I recently retired from the San Francisco position to beautiful Bainbridge Island that you're looking at right now, which is about 7 miles west of Seattle. Now, in full disclosure, I should mention it doesn't always look like that. In fact, that might be a good color slide for the Chamber of Commerce. But in the spirit of full disclosure, I would say it has a little different cast to it as far as the weather. And I've heard all the funny raps about the weather in the Northwest. But I have to tell you, nothing has dampened my interest in this topic because it has been so controversial over 40 years. And 40 years is notable because it's mentioned actually in the Bible over 140 times, and it's symbolic of a period of time to investigate or test old beliefs. And we are actually at an inflection point because we've been able to discover a prevailing belief or a myth that has handcuffed us from having a rigorous evidence-based answer to the question of whether teeth and implants are similar and how that impacts our treatment planning for our restorations. So let me be more precise about the issues. When I'm speaking about teeth versus implants as the basis for a lot of our decision making, I'm not so much speaking of this issue of when you have a 1-2 space, are you going to restore it with an implant or with a 3-unit or even a cantilever prosthesis that's tooth-borne? These two options have been looked at very carefully over a 10-year period, and Young has shown that the 10-year rate of survival is about 89.2.4%. So very similar, and actually similar success with oral health impact profile being very similar. So that's not something we want to debate today. The question that I see amassing has to do with once we have the ability to place implants, once we decided we're going to be placing implants, how do we do it? What are the permutations that we would follow for the patient's best interest? For instance, if you have a 3-2 space like this, is the gold standard to put 3 implants? Or would you consider a medial ponic or even a cantilever ponic? And what if these were short implants? Would you recommend to splint them? And what if the crown to implant ratio was, let's say, 2-to-1? If you're on the maxillary arch, would you then engage the surgeon to do an antral augmentation in order to increase the length of the implant, to change that untoward crown to implant ratio? And then if you had 2 implants, for instance, in the posterior, would you consider definitely splitting them or not? What if they were short? And would you consider a cantilever? In other words, having a mesial or a distal cantilever, so a single implant carrying that. Now, I can tell you that these questions were bristling over the period of time that I was at UOP during those 14 years. And halfway through, I was compelled to publish a book on this topic, thinking that that might move the needle in terms of this controversy, because there were certain convictions that were not they were not mutable, they were not changing even after this particular project. So that's when I began to look at this from an intriguing view, that there were some embedded ideas that weren't going to change unless we found out what was the basis of it. And actually, to to start to unpack this, we'll have to go to the trailhead. But before, meaning, when osseointegration was discovered, but before I do, I want to take a poll in this webinar room. And I want to find out just where the state of the controversy is today. So, for instance, would a distal cantilever implant process lead to more marginal bone loss than 3 adjacent implants? Can you register a yes or a no in the chat? Okay, second question. Would splinted short implants preserve marginal bone better than solitary units? And lastly, would a crown to implant ratio of 2 to 1 lead to more marginal bone loss than 1 to 1? Okay, has everybody registered their answer, yes or no, on each one of those?
We have responses trickling in, yeah.
Okay, so in the beginning of 2025, I actually posed these questions to ChatGPT and published the responses. And then, of course, I did some prompting in order to find out if they would stick to their guns or change the responses. It's a pretty funny article, actually. But I can tell you that ChatGPT's answer before any more prompts was yes to all of these. Now we're going to have to see whether ChatGPT was right or you were right, depending upon how you answered. What is fascinating is that ChatGPT at that point was drawing on 4 sources. One was dental school guidebooks and dental textbooks, online topics, online platforms on this topic, and lastly, published articles, but in an unfiltered way, just to give you an idea of what they were drawing from. Okay, so let's begin, like I said, at the origin of osseointegration, 1982. Actually, that was the year that I graduated my prosthetic residency. So Brandemark, as most everybody knows, at the time of this discovery, which was 1952, he was an anatomist, and he was looking at microcirculation in the tibia of a rabbit and was flummoxed because he could not remove this titanium ocular chamber from the bone. And everyone, of course, was aware of the fact that he noted there was an actual structural attachment of bone to titanium. But that wasn't really the full measure of his serendipitous discovery. He went one step further, which is so important in this area, and that is he looked for an unmet need outside his discipline. He was more in medicine than dentistry, obviously. Eventually, he became a surgeon. So what he noted is that what he called the mandibular complete denture cripple or amputee was going to be tethered to a vat of adhesive if he didn't have some help. And so he created this tissue integrated prosthesis, which was so revolutionary. That design could have never been done on teeth, okay? And the assumption was that it was totally integrated. And it was integrated in the bone. But there was another integration that at the time was being investigated that he wasn't aware of. And I call this the integration in the dome, which is our head, as opposed to the bone. And it was actually Daniel Kahneman, who was a Nobel laureate, he passed away about a year ago, and Amos Tversky, who collaborated on this question of, okay, what do we do when we are exposed to some kind of novel innovation or a revolutionary idea? Is there a mental response that is replete with us humans? And actually, they found that there was. And they published a book the same year that Brandemark went to the Toronto conference to introduce osseointegration, 1982. and called it judgment under uncertainty. And that is, they purported that there was a phenomenon called heuristics. And that is that when we get exposed to something new, we are not totally open to that idea. Instead, what we do is we associate it with something we're familiar with. And that creates what we call, well, what they call cognitive fluency, or a little bit more ease with this mental step. And then we go one step further. We actually look for evidence to support this association or link. Now the question is, did this happen with osseointegration, with our entire chronology from the start of the introduction of osseointegration to today? Could we actually cite that this was happening, what they purported? Well, this is what I want to make the case about. Well, first of all, let me ask you, what do you think that the mental shortcut did in terms of what was the association of implants to? Well, actually, it was implants are similar to teeth. And this is somewhat of a conundrum because when you look at the gingival complex, it's totally, vastly different on the implant side it is on the tooth side, as well as the attachment apparatus, as well as the vascular plexus, which is so much more plentiful on the side of the tooth than it is on the implant. But in spite of those differences, what happened is that this core belief, remember we were talking about this kind of prevailing belief or myth, shaped the truth. How did it do that? Because that connection then was the basis for looking for evidence to support it. So let's see, did this really happen? Well, let's take a look. 1997, Bo Rangert, who is well known for his three-dimensional computational geometric analyses, was taking a look at the different permutation of design, where we start with one implant per tooth, and then he looked at the stresses that would amount to changing it to a medial ponic and then eventually to a cantilever. And what he showed is that you're going to get 50% more stress to the surrounding bone if you go from a one implant per tooth design to a 3-unit partial prosthesis with a central ponic. And then 100% more from there stress to a cantilever. So that was a bit of a warning about cantilevers, as well as a bit about changing it to a 3-unit fixed partial prosthesis with a central ponic. And then just last year, Gelfand did a strain gauge analysis and also looked at the deformation in the bone based on the design. And what he found is interesting, that when he went to this 3-unit fixed partial prosthesis, that instead of a 50% increase, he only found a 25% increase, but there was an increase. But with the cantilever, he found a 491% increase to the surrounding bone in terms of the stress gradient. So they concluded that especially cantilever prostheses showed the highest strain among the 3-unit prostheses, which sounded like a all-on-deck warning that we should be very careful about using this design in our implant restorations. Now, the question is, could one make a link to teeth in terms of cantilevers, right? Because we're saying cantilevers don't work well in terms of the forces that are going to be generated to the bone. What about teeth? Well, interesting, a year after Bo Rangert's work, linguists did a very interesting clinical study to show that when he was comparing cantilever restorations on teeth with non-cantilever ones, there was a big spike in failure, especially between 8 and 14 years, but at every uh, time slot, the cantilever prostheses did not fare as well as the non-cantilevered ones. And then Terry Walton, who I would say, and I think with ease, that he's probably the greatest clinical researcher in the world. He works out of Sydney. And he showed that looking at 515 metal ceramic FPDs, that cantilever prostheses have a significantly higher failure rate. And it's ironic because if he found that they had a high failure rate, and is probably the most meticulous operator that I know. In fact, to the point where some people say his work doesn't have external validity because nobody can operate at that level, he still found these to fail at a higher rate. So, has the link been made between implant cantilevers and tooth cantilevers? Yeah. Well, let's move on. What about the question about short implants? Should they be splinted? Well, Carl Misch, who is well known for his biomechanical analyses for implants, he noted that when one was using 7 to 9 millimeter implants, that the survival rate was not even close in many cases, up to 8 times worse when compared to longer implants. And so what did he surmise? He said, if we're going to fix this problem, why don't we look at teeth? And that's what he did. He said, we could improve, for instance, the overall surface area of a short implant if we splinted them, had 2 implants or 3 implants that were splinted. That would be far better. And he even suggested increasing the diameter because he said, look at molars. What do you see about them? They're close to the fulcrum and a lot of force being generated, but they do well. Well, they have a wider radicular base, so maybe we should widen the diameter, but they have fused roots. Therefore, we should splint implants. Do you see how this concept about teeth and implants certainly got support here? And then Berkowitz, this was in 2008, 3 years later after Misch did his work, he found that with this finite element analysis, you can reduce the stress to the peri-implant bone 9 times by splinting when it's compared to a solitary short implant. And then later, Mansour showed that actually the most effective thing is to splint in this case in a finite element analysis rather than to widen the base or the diameter of the implant. So, how does this relate to how we treat teeth? Well, when you think about orthodontically resorbed roots, truncated roots, how do we handle them? Certainly having an A-splint is often used in order to withstand those forces with that kind of crown to root ratio. So it was interesting that Misch did do this study and compared the splinted short implants with the longer implants that weren't splinted and found out a similar failure rate of 1%. Again, to support his thinking. Okay, but remember, these were machine implants. Okay, so let's go to the third question, and that is crown to implant ratios. And Very showed this incremental change in the crown to implant ratio from 1 to 1 to 1.25 to 1 to 1.5 to 1. And as he did it, he found this increase in or heightened stress intensity in the fixation screw area. And he said that caused a displacement in the bone. And a similar study was done with de Moraes, where again, he looked at the same types of change in crown to implant ratio. And as we got close to 1.5 to 1, you can see that area of orange red where there was a magnification of stress concentration at the platform and abutment interface, causing again what he called bone tissue stress and deflection. Okay, so we all are familiar with the fact that when you get a crown to implant ratio that's greater than 1 to 1, that doesn't bode well. It certainly does have this. Can you hear me?
Yeah, we lost you for just a couple of seconds, but you're back.
Okay, I hope that's not going to be a problem. Okay, so here's the question. In all three cases, where we started with the issue of three implants adjacent for a 3-2 space, and then going to either a partial prosthesis that's even cantilevered, and showing that both with implants and with teeth, that doesn't work as well in terms of the forces on the peri-implant bone. And the same issue with short implants, that certainly splinting them reduces the force around the implant. And now with the crown to implant ratio showing these high stresses at the interface. So what's the problem? Wasn't the case made that implants are similar to teeth? Well, actually, it has to do with the type of evidence that's being used. And, if we're being asked to have a crystal ball and for our patient to say, what's the chance that I'm going to have a good outcome? You say, well, it depends on three inextricable factors. And this triad is made up of patient, operator, intervention. And we know from the patient now analysis, we're starting to look at not only systemic risk factors, but also what's above the nose as well as below the nose in terms of what the psychological makeup of our patient is, compliancy, and all those things. As an operator, we're starting to look at that more clearly too. I mean, Lambert showed that if someone has placed less than 50 implants, they're going to have twice the failure rate. So experience makes a difference. Specialist versus generalist can make a difference. And then also, Renard showed that those operators that are under stress are making non-technical errors. So we're scrutinizing these things very well, but are we scrutinizing the intervention? And that really has to do with the work of David Sackett. And that is the evidence that we're choosing. Is it of high bias methodology or low bias methodology? Because that's what he purported, that these studies in this array, systematic reviews and RCTs, prospective studies, they have the least bias in terms of their outcome measures. So where were the studies that we were talking about? They were in the lower area, right, where there's most bias. And this comes down to what I call internal and external validity. Because, I mean, Sheth did this study recently and gave 12 criteria for what would be actually a valid in vitro study. But what he meant to say is what would be a valid internal study. Internal validity is something that, yes, he could establish with those 12 criteria. But the external validity has to do with what about the clinical consequences, the clinical significance of this particular study. And that was the problem with these in vitro studies. Now, there was one clinical study that actually was done, right, by Carl Misch. And Carl Misch showed, yeah, hey, there was the same failure rate, 1%, with splinted short implants and non-splinted longer implants. But what was the problem with that? It's not externally valid for today with textured surfaces because the textured surfaces don't respond like that. But with Carl Misch's reputation, and he tutored and advised 4,500 dentists in his institute, you can see where this got a lot of traction. Okay, so what do we want to do? In order to now understand these concepts, we have to submit it to a much higher hierarchy or rigorous study than these studies were used. to create the myth that implants and teeth are similar. So we'll start with this simple one. It was a 14-year study by Yi that just looked at one implant per tooth space, so in a three-tooth space, and found out that the survival and success was the same. In fact, there was a little bit more mechanical issues with the fixed partial prosthesis, but with the splendid three-unit on three implants, they actually found more biologic issues in the medial implant. So bottom line is there weren't any differences here that could be related to so-called in vitro studies showing, oh, there's higher stresses when you go, even this 25 to 50% to a partial prosthesis. So that could be put to rest with this very strong, rigorous study of 14 years. And what about systematic reviews and meta-analyses? And this one by Freitas da Silva says it all, and that is that a mesial or distal cantilever was similar, did not compromise bone loss. Of course, there are caveats. We can't have a longer than 8 mm cantilever. We won't make a molar-sized cantilever. It needs to be more of a bicuspid, even in a molar region. So that's one caveat. And then we're not using them on bruxers. Okay. One of the other studies that was it was almost too remarkable because this was a 10-year study by Curtis Becker, and 5 of them were on just one implant carrying one cantilever, and the other 55 were 3 units. And what he found is no fractures, so no mechanical problems, and no bone loss. And so began to look at this more carefully because it was hard to believe this data. And it turned out he used tissue level implants, and there were some advantages there. First of all, the microgap is farther away from the bone, as we can see that. So that helps with the biologic response. And also, just the architecture of a tissue level implant with this ferrule, it resists tensional forces, and that actually reduces ceramic fracture. So there was good reason he had good results. And again, advice to use this design when you're doing cantilevers. And then we'll go one step further. That will start to maybe strain some credulity, and that is with these 2-unit implant cantilevers compared to one implant per tooth. And with this systematic view and meta-analysis, same type of survival rate. There was a little bit more mechanical complications with the cantilever, but it wasn't significant. And there were heterogeneous results. Now, that usually sounds negative, but what it really meant is that this worked in the posterior maxilla, posterior mandible, anterior as well. So there wasn't one section of the mouth that this would only work in. So here's the question, guys. Let's be frank about our thoughts. How is this possible? You have a tooth that has a periodontal ligament, and it's supposed to act like a stress reliever, right? And you have an implant that doesn't have that. Now, why would an implant fare better carrying a cantilever than a tooth with a stress reliever? And now you can see how some of these ideas have been embedded because our intuition says one thing, right? And now the evidence is pointing to something else. Well, it was through my work at the Stanford Animal Research Lab that I began to get a handle on this because I didn't understand this either. So first of all, the periodontal ligament, we know that it does act this way. It can act as a shock absorber depending upon the force, and it's lacking in the implant microenvironment. And to the degree that even Axel Kirsch and Babush and others thought, well, what about actually creating an analog of the PDL? And this was this intramobile element. Wouldn't we benefit the mechanical load on an implant if we did that? Well, the answer was no. It just became a maintenance nightmare. And in fact, the funny thing is, this was the title on PubMed, and they misspelled rationale. It's rat now. And so it really didn't have a rationale. So here's the thing, guys. This is what I found out through histology. And what I say is histology exposes mythology because after a tensile stress of about 6 to 7 megapascals in the PDL, what happens is something absolutely un unintended in your mind, and that is that it can lead to apox, anorexia, not, I'm sorry, anorexia, anoxia or hypoxia, where you get a release of these pro-inflammatory cytokines as well as tumor necrosis factor, rankle, and other ligands. And what do? They actually begin osteoclastogenesis or to break down the bone when you get above the 6 to 7 megapascals of force. Now, what would that be like? Well, for instance, if you had a balancing interference on a second molar, do you try to eliminate that? Yes. Well, it's close to the joint, and that non-axial force is pretty big. Actually, it is. It's above 6 to 7 megapascals, and that's why you get bone loss through this process of osteoclastogenesis because the force is high. Now, on the side of the implant, we don't even know what the threshold for peri-implant bone overload, but it's probably at least 3 times as much. And hyperloading actually leads to improved densification of bone or anabolic changes. So if you had a similar non-axial load on a second molar implant crown, we don't eliminate that for the purpose of worrying about the bone. We do because we're worried about the restorative possibility of fracture, the ceramic fracture. Okay, so here's a finite element analysis, quite different than the ones I was showing you before, because it's not about relative stresses and saying, oh, this is a big stress, you better not do a cantilever. This is about relevant stresses because what we have here is the stress in the PDL, which we said on a cantilever is higher than 6 to 7 megapascals. Actually, it's around 9. But the maximum strength is 6 to 7. So therefore, the rate limiting factor is the PDL. The stress in the bone is, actually about the same. The problem is that it's the PDL because if you look at an implant, the stress in the bone is a little higher because we don't have the same configuration of the root. But look at this fatigue failure of the bone when we have the stress of a cantilever implant prosthesis. It handles it just fine. It's well within the estimated ceiling of that fatigue failure. So that's why implants that are cantilever do better than teeth, because implants don't have a PDL, which is the rate limiting factor. What about short solitary implants? Well, there was a 10-year study that was done, more than a couple hundred unsplinted implants, 6 to 8 millimeters long, and they fare pretty well, even in type 4 bone, with marginal bone loss minimal, and the biologic complications were pretty low, with 12.5% mechanical complications. So all in all, 10-year study showing this can be done. They do not have to be splinted in posterior bone. And on the mandible, the same thing. This happened to be split mouth design, which is always favored because we're controlling for a lot of the variables. And with about 40 some implants with 6 millimeters long, found out there was no difference. And this is kind of interesting in the days of PFMs. The great thing about it is you could try the metalwork in as opposed to a zirconia where you can't do much with it if things are not splinted well. But at any rate, the point is that you could test everything from the embrasure to the fit and also put these little metal stops on and test your occlusion before the porcelain was put on. They remove those before the porcelain's on, but it gives you an adequate test of that. And now, excessive crown to implant ratios. And this is where more people scratch their head than in any other area because, again, it is so counterintuitive. When you have this kind of crown length over that implant, one would say that's awful lot of stress and deflection on the bone. But the point is, we're learning what that fatigue failure of the bone is, and we're also learning what hyperloading is. And hyperloading is what you do when you go to the gym, right? To get more muscular and stronger bones. You don't go to the gym saying, "Oh, I don't want to stress myself out here. I'll stick to the 1 pound dumbbell." And again, solitary crowns did not differ from splinted ones. Counterintuitive once again. Uh, so the last thing is we recently found out from Gamberin that there are also no more serious prosthetic complications from these unsplinted 2-to-1 crown to implant ratios. So once we learn that, now we're going in a direction that's quite different in terms of treatment planning and over-engineering. When you look at finite element analysis, why did we come to around 2.5 to 1 for these studies? Well, that's because we know generally we're assuming the fatigue failure of the bone is around 16 megapascals. And when you get into 3, you're challenging that. So anywhere in the 2.5, we're still within that. And that's how we came to that limit in terms of crown to implant ratio. So let's go over some clinical implications here. This was a patient I recently restored, and it actually involves some completely edentulous as well as partially edentulous decision making. And he had, as you can see, completely abraded his crowns on the upper arch and in the posterior mandible and quite a bit of the anterior mandible. And so when he came to me for years, he said he just never smiled and nobody ever saw that he didn't have teeth. But he was finally at a point where he said he wanted to have a possibility for a smile. And so when we looked at his lower anterior teeth, we could tell where we must go in terms of a wax up to have a contour that's appropriate. And we started with that and used the retromolar pad as a guide for the occlusal plane, halfway up the retromolar pad. And then instead of discarding these teeth that were heavily abraded, we removed decay, and the ones we could save, we couldn't save number 29. And I used an old technique, it's the pin buildup, because I didn't trust the bonding technique, probably because of my age. And we went and we restored him from 28 to 22. And this is where I used the Visalis, which he had the possibility of a strong bite, although he wasn't restored up above yet. So I still wanted something that had a very high flexural strength, and that's what Visalis does. And so we restored these teeth for him with that. And then the whole issue of vertical dimension comes into play because we've lost all our landmarks. And I think there's been a lot of confusion about how to assess vertical dimension when I really believe it's quite simple. That is, rest position is something that doesn't change with age, thank God. And we can put a dot on the nose and chin and take a Bowley gauge and barely have his lips touch, and we can get a measurement. And for a class 1 patient, we can put in a record base with a wax rim, after we made him his at least his provisionals. And then we can establish what the VDO should be, which is about 3 millimeters less than the class 1. Okay, so that should be pretty simple. But without that, if we make a mistake here, then everything we do is going to be subject to breakdown and also his lack of adaptability. So in this case, when you have a trian, a wax trian, you have to be careful because usually what happens is they make a record base for you that then engages the vestibule on the buccal aspect here. But he had no room for that because he didn't lose any bone here. He's only lost his crowns. And so what I did is I actually took the cast and I built teeth right over those roots. And then what I did is I took an impression of that and then dropped a vacuum form template and put composite in there in order to establish the aesthetic and functional goals. And then we check with the Coyce analyzer to see what his plane of occlusion is, check the midline, and then check the aesthetics with that setup. If you do it any other way, you're going to get displacement of the lip. You're not going to be able to assess things aesthetically. And so this worked out for us. Now, we finally restored those teeth from 22 to 28, and then we placed implants. Now, why did we place implants in that position? Okay, uh, we could have placed two implants on the right. There really was no financial limitation that he had. He was very well off. But at the same time, based on what we know, having a cantilever there, and it was fine with him, and we also measured with an Innovite what his force would be with a denture, and it wasn't anything close to being a Bruxer's force. He could have a cantilever there, a molar cantilever, and then on the other side, we had a fixed partial prosthesis with a medial conic. That was our design based on the evidence that we've seen. And the way we took our bite registration after we took our impression is we fabricated that cast, and then on the two tissue level implants, and remember when I said you're doing cantilever, it's best to do tissue level, I use the snap-on, and I actually adjust the interior part of it, the height of it, so I can make a prep index, so I can take a bite registration. And here's an example. This isn't his case, but it's one close to it. And this is for the bone level implants. The Straumann has these prep indices. So you can take a registration, give yourself a tripod. Otherwise, you would not have the ability to relate the upper and lower casts. So with the tissue level, I used this snap-on and cut it down so it would not be in the way of the maxillary arch. And then on that one bicuspid, number 21, I used this prep index. And then we took our registration, actually took it with Futar. And the great thing about Futar is it's thixotropic. And what does that mean? It's kind of like ketchup. You know, when you are putting ketchup on your hot dog, if you don't shake up the bottle, it doesn't really come out. And that's what Futar is like. It doesn't have high flow unless you go ahead and put extreme force on it, or you're creating that kind of pressure. And I like that because it doesn't get into undercuts, especially when you're using this prep index design. And also, the great thing about Futar is that it sets up in a very rigid fashion so you can trim it with a scalpel and not worry about creating these partitions of the registration. So this was his maxillary denture. We did put a framework inside because he did have some increased force. And then this was an immediate after the roots were taken out, and we did use a tissue liner. And I have to tell you that using mucopren would even be a step forward, I think, because as long as you use the adhesive, this mucopren adhesive, the great thing about it is that you can apply it wherever you want it. Okay, so if we're going to go back and add to some area, you can apply it from the syringe that is in that carpule. And this is so great. As well as it does come out with a very clear mix as well. So I like the advantages of that. So here we are. We did a Panacil reproduction of the denture. You don't have to worry about any moisture in that case, but Panacil is a little bit better because it's hydrophilic in the mouth, although I still would do everything I could to have a dry environment. And so here we are, we mounted the case based on those prep indices that I told you about. And then we fabricated screw access on all these designs. Now, why is that so critical? Well, it's certainly critical from the standpoint that because of continual craniofacial growth, we do get sometimes opening in these proximal areas where the contact opens up. And if that happens, the best thing to do is to remove these prostheses and add to the contact. When you have a cement retained design, you sometimes have to damage the restoration in order to remove it. So that's one reason. The other reason is obviously if you have any other issues with the prosthesis, it can be removed and you can put a new screw in it or whatever, depending upon what it is. You definitely want to have retrievability. And that comes back to a conversation with a surgeon where the restorative person and the surgeon should be viewing the CBCT at the same time and discussing where that should be placed. And we found through Monhe's work that if you don't place the implant centered in the tooth edentulous spot, that it causes more periimplantitis because of the fact that you can exceed a 30-degree emergence angle. So yes, the restorative person can do gymnastics in terms of getting it to be restored, but can he prevent periimplantitis when mistakes are made with too buccal of a placement or not a correct centered placement? And remember, whenever you have let's say, an edentulous area, say number 19 missing, you must address the proximal wall of 18 and 20 because you want to make a guide plane, not just a point contact. Because the biggest complication for implant prostheses is food impaction. And that is caused by open gingival embrasures. Once you extract a tooth, you lose the pillow. So what I'm saying is you restrict that, you minimize the gingival embrasure by having a long guide plane. Now, if you do that after surgery, it can change where the implant was centered. If you're taking more off the molar, for instance, the bicuspid. Okay, this was the definitive prosthesis. You can see the framework on the maxillary arch, and then you can see where we place the tissue level implants and the one bone level implant. And this was his final aesthetics. Okay, I'm going to give you one more treatment planning dilemma and then point out where this leads. So this was a patient that came to me. Actually, she wanted to have some veneers done on the maxillary arch. They were breaking down, so I did that. And what I used, what I call the Kenmore shade guide. Of course, Kenmore is a refrigerator. She started with white, 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 so I had to stay in that territory. But that even the bleaching shades were pressed to quite get that. At any rate, here was her question. She went to find out how she could get one more tooth in the posterior for chewing. She felt like her chewing was being restricted. Now, what did she have? She had 4 teeth carrying 10 teeth. She had 4 teeth that were ponics from 23 to 26. And then she had a ponic second bicuspid. Now she wanted to have a molar, even if it was a bicuspid size, on 19 and 30. So what do? Well, we could probably get an implant in the area right below that ponic, but going farther posterior, there's just no room over that IAN. So the question is, what could be done? Well, she went to Clear Choice, and they made their clear choice. And they said, let's take out those lower teeth. And this is kind of interesting because Matrani just recently did this study on terminal dentitions and said, well, if you have as much as half of the attachment lost on them, on the teeth, you should consider removing them and putting implants in. And that was one of his algorithms for a terminal dentition. But what did we do here? Well, actually, we placed cantilevers, distal cantilever on a short implant. Okay, that's how we restored her. And remember, going back to this question about the remaining four teeth, yes, there was attachment loss, but there was no mobility. Very important for you to understand that as well. No mobility. Okay, so how did we support doing this kind of minimally invasive work? Well, through this study that was done by Haug, cantilever single prostheses on short implants, 6 millimeter implants, perform the same as those with conventional fixed partial prosthesis up to 12 years and more. So this can be done and safer from a much more invasive and costly procedure. So here's the thing that I want to tell you about that this has impact on, because with Mitrani saying if a tooth has half the attachment loss, consider taking it out, we really need to look at the evidence about this, because there's systematic review done in 2022 and it looked at both implants and teeth in terms of their survival rates. And they found out they're the same, pretty much the same. When you have a compromised periodontal problem and when you have implants on compliant patients. Okay. But what was different is the success. Much better success with teeth on compliant patients. Okay. So what's going on here? If you look at this study by Rasparini, and this was a head-to-head contest, I would call it, where they put implants in patients that did have some compromised periodontally evolved teeth. And then over 10 years, they looked at, well, which lost more bone? And actually, the implant lost more bone than compromised periodontally evolved teeth. But here's the caveat. It was on patients that were highly compliant, coming in for regular care and treatment and maintenance at home. So given a compliant patient, maintaining periodontally compromised teeth has a better outcome than placing implants. So once again, looking at the histology, we begin to understand this, because on the biologic front, it's quite interesting. We have these Sharpie fibers that are these connective tissue attachments that are very strong and arranged in an oblique way that helps to resist downgrowth of bacteria. And the dominant cell is the fibroblasts, which are pluripotential. They can differentiate into their own fibroblasts or osteoblasts or cementoblasts. And we have mesenchymal stem cells available, as well as macrophages and mast cells, and this rich vascular plexus is part of the PDL, which you do not have on the implant side. So everything's quite different. You have, very tenuous hemidesmosome attachment in a parallel fashion rather than oblique, poorly sealing, diminished blood supply because there's no PDL and no stem cells. And also, when you look at it, if you're looking at a platform switch, that's below the tissue and adds to the a nidus of colonization of bacteria. And not only that, Monhe did the study to show that if you don't place that implant centered in the edentulous space, you're going to have more periimplantitis. Or if you place it too buccally, or if you place it in a zone where it's greater than 4 or 5 millimeters apically placed, or if you don't have at least 2 millimeters of soft tissue, or if you don't have sufficient keratinized tissue of 2 millimeters. All those things compromise the implant outcomes for potential periimplantitis. And this says it all, really, because not only do we have a different defense that's inferior on the implant side, but the treatment is also problematic on the implant side, where we have almost half recurrence and a fifth of them fail. But on the tooth side, even with 50 to 70% bone loss, that's nothing like we're talking about on the side of the implant, we have only 12% or an eighth failing. So again, supportive, compliant patients. Okay, very important. But take a look at the difference here. So, what do we take away with here? It seems like where the PDL was the rate limiting factor before, the absence of it is the rate limiting factor on the implant side when we're talking about biology rather than mechanics. And that's where I would say we would have to rob Peter to pay Paul. I say Peter because that's the PDL. But this is what the thinking was with this preclinical study on a beagle. And the great thing about it is that we can do this in a very logical fashion. We can go ahead and take out a tooth, and then we can place an implant 3 months later. And then in another 3 months, we can go ahead and put the healing abutment on and then place a ligature to mimic periimplantitis. And then 3 months later, once the periimplantitis has aggrandized, we can go ahead and remove the ligature and do a open flap debridement. And then in another, say, 2 weeks or so, we can do regenerative therapy. And what is the regenerative therapy? Well, at that point, they actually took the stem cells from the Beagle PDL and along with the collagen gel and hydroxyapatite particles, they got a pretty good fill, more than 70% in many of the lesions. And you can see that here with this new bone on histological section. So when I saw this, I began to think, okay, how can we bring this to the clinical amphitheater for patients? And it was interesting because I came across this article in the New York Times, and it was about using the placenta in soft tissue wound problems. This was actually in a burn victim, and it it spoke of the remarkable results from it because of stem cell and other regenerative abilities with growth factors and others. And it just so happens I read this, it was on my birthday last year, and it was a big birthday present because I thought from that point, okay, let me go on PubMed and see if anybody's used a regenerative technique that's from this type of placenta-derived material. And actually there was by Vinay Bide. And since then, we've got to be close friends. But what he showed in this 2-year proof of concept is that he could take a pretty radical lesion. You can see that it's almost 80% there, and get a complete bone fill in 2 years using this dehydrated, deepithelialized amniochorion membrane along with a xenograft at the time. And basically what he did is he opened up this full mucoperiosteal flap, and he identified 9 threads that were exposed and went ahead and did the degranulation and then decontamination with 3% peroxide, as well as the titanium brush to eliminate any more of the toxicity. And then, like I said, use a particulate xenograft. And then this membrane, which was the placenta-derived membrane, which is very easily handleable, and then got the result which I showed you. So what's going on here is that there's a number of factors that are working well. Number one, this amniochorion membrane is pretty strong. I mean, the amnion is it's very thin. It's only like 20 to 70 microns, but it does have this structural support of the chorion, which is highly fibrous. And then the beauty of it, it has low immunogenicity. Well, first of all, by de-epithelializing it, that really helps. But in two similar, let's say in two non-similar recipients, it doesn't cause any difference in the inflammatory response. And also the membrane and derived cells, they actually cause uh, a inhibition of T cells, which are responsible for this immune rejection. And then it secretes a host of biologic factors such as growth factors, cytokines, chemokines, and also tissue inhibitory molecules against metalloproteinases. And they're the ones that can really uh, deregulate or dysregulate the extracellular matrix, which is so important for healing. So it does all that as well as recruits endogenous progenitor cells. And we were so impressed with this, we said, how do we make this even more, let's say, credible? And going back to our well thought out issue about hierarchy of evidence, we need to consider a randomized controlled trial. And so I went to Loma Linda. I have some friends there with Jaime Lozada, and Joe Kahn is there. And we filed for an IRB in order to have 52 patients, split them up in two arms, one using this amnion chorion membrane, and then the other with a collagen membrane, and see if we get a result. In this case, the inclusion criteria was for no more than 30% bone loss, or 33%, with a 2 to 3 wall defect. And at the same time, we're not going to be treating patients that have perio disease that is active, diabetes, smoking, or other contraindicated medications that might lead to ONJ or others. So the key is that we are going to work on the posterior arch. We're going to remove the crown. We're going to relegate them to the healing abutment and then use this technique. And in 2 years, we'll find out if there's a difference in a very classical way that has low bias. So the question that we're talking about today and how it affects treatment planning is, are teeth superior to implants? And the answer is no, mechanically. And this is why we made choices that are minimally invasive. And then, yes, biologically, they are. And again, this is a way to preserve what's there rather than the meticulous replacement of what's going to be missing. And so, all in all, when we make these decisions on one implant per tooth being the gold standard, no, not true. Cantilever implants being inferior, no, not true. That we have to splint all short implants, no, not true. Crown to implant ratio being a killer over 1 to 1, not true, just the opposite in some cases. And maintenance of periodontal involved compromised teeth, yes, on compliant patients. So you might say this is the basis for minimally invasive dentistry and implants, and at the same time, maybe minimally intuitive dentistry, because we didn't understand before we saw the histology what was really going on here. We were just using our brain to make this connection with what we know about teeth. Okay, so thanks a lot. I'll leave you with this. It's not what we don't know that can hurt us. It's what we know for sure that just ain't so.
All right. We will thank you so much, Dr. Sadowsky. Let's open it up to questions. Should we not measure a patient's bite force capacity to find what the actual load will be placed on the supporting bone via the prosthetics?
Okay. So this is a very good question. And in fact, I did have some InnoBite readings for you. I probably should have included them. Because as we said, for instance, when we're using cantilevers, we don't subscribe to patients that are ruptures. Now, what is that zone? We're talking about in the zone of around, 800 to 1,000 newtons, or, talking about 200 to 250 pounds. So it is a good idea to measure that. You can measure it before you do the prosthetic design because that's not going to change. Okay, as long as you have teeth or something for them to bite on, that'll give you the masseteric force. And that's what you're looking for because that's going to help you decide whether you can use a permutation like the cantilever design. Okay.
Next question. On first patient, why the maxillary anterior diastema on denture?
Okay. Excellent question. So this is what I want to show you. Okay. Can you see that?
Yes,
Now we're
we
looking at,
can.
okay. So do you see the space between this and this? 8 and 9? So the patient had a space. Now the question is, what does the patient want? Because he has the ability to change that with a denture, but at the same time, I like to inform the patient that this is a signature. In other words, what I like to do is recreate what's missing. Why? Because the patient's used to it, but also because his friends are used to it. And we like for our work to go unnoticed. They say excellence goes unnoticed. In other words, for people to say, gee, it looked like you got a haircut, rather than say, oh, I see you got new teeth. So if we can recreate what was missing, and Lombardi spoke about this, I think we can get closer to restoring the patient's own sense of self-prestige and respect, and at the same time, make for a very functional change back to the way the patient was. So here's the point that I want to underscore. This is something you want to discuss with the patient, that you can recreate what's missing. Like with another patient, their essentials were visibly buckled to their laterals, and I recreated that. And I remember the wife telling me afterwards, I'm so glad that you did that because the teeth look authentic like he had them before. At the same time, there are patients that have spent their whole life with crooked teeth, and now they think they have the opportunity to change that. And they tell you, no, I don't want it to look like that. But what I do is I ask them to bring a picture of them in if you have it. He did not have it, by the way, but some patients do. And then I say, would you like me to copy that? And that gives you the permission to go in the direction that you want to go at that point.
Okay, next. First of all, hello from a past prosthodontic student, Carrie Goldstein. You
Oh,
still,
Carrie Goldstein. Oh my God. You're still learning, huh?
they say you still have the goods. Excellent lecture. And the question is, so what technique would be best for repairing bone loss around implants today?
Okay, so that's the question that was looming so big in my mind after I look at the evidence and the fact there's such recurrence, Carrie. Um, and the issue is this: we don't have a good technique. I actually published an article on this in 2024. It was 40 years later, what are the mechanisms and what are the indications and what are the outcomes for peri-implantitis treatment? And the sum total of that article was we are in need of revolutionary treatment. And that's why I was so compelled about this regenerative treatment that I mentioned. So, in answer to your question, I don't think we have anything right now. I mean, a reconstructive technique is better than one that is not. Just antimicrobials aren't going to work when we have peri-implantitis. They help with peri-implant mucositis. So, bottom line is, we don't have it yet. We have some things that can help, but I'm hopeful within the next couple of years to say to you, let's use this placenta-derived membrane and expect to have a pretty darn good fill for our patients.